We're moving on to the second session about treating cardio, renal in the middle, the most important one in the middle, metabolic disease. I'm joined by some colleagues as well as Dr. Chatterjee, who's online to chair the session. And it's the same format as last time, where we're going to go through some talks and then we have time for discussion at the end. So I'm not going to hang around any longer, but to introduce the first speaker, Christian, who's going to talk about cardiorenal metabolic syndrome disease, the size of the problem. Thank you very much.
Thank you for the introduction. Oops. Okay. Very well. So my presentation is to set ground also for the other presentation of cardio-kidney metabolic syndrome. So I will talk to you about the size of the matter and why do we care about this. As you can see, cardio-kidney metabolic, we have defined it as a disease in 5 stages from 0 to 4, from no risk factor to actually established cardiovascular disease. But there are stage 1 and stage 2, which we'll focus more, where actually the size is extremely relevant. And let's start with stage 1, so the root cause of cardio-kidney metabolic, one may say that is obesity. Those are data from the global burden of disease. So as you can see, obesity has been rising. We know that very well. So much that from 1990 to 2022, the prevalence exploded both for women and men almost everywhere worldwide, to an actual prevalence of obesity of 18.5% for women and 14% for men. What about metabolic syndrome? We know so much that metabolic syndrome is important that we are actually now discussing to integrate liver endpoint in clinical trials in cardiology and kidney disease. So this actually gives you the importance of metabolic syndrome. What about chronic kidney disease? We know that the burden of CKD is huge. We're talking about 1 billion people affected by chronic kidney disease, with CKD being present in almost 35% of patients with diabetes, 1 in 4 patients with arterial hypertension, and 35% of patients with cardiovascular disease, with projection leading to a 24% increase in prevalence of CKD and up to 37% higher costs from now to 2027. So much so that CKD will likely be the 5th highest mortality burden by 2040. And if the prevalence is increasing, it could be by a lot of different stuff. Like for obesity, there is a shifting in the epidemiological data, but for CKD, maybe we are treating patients better. That's why the prevalence is higher. But on the other hand, maybe we are diagnosing more. I would love to tell you so, but this is not really the case. Those are data from the REVEAL CKD showing that 50 to 90% of patients with stage 3 CKD go undiagnosed. This is from electronic health record. But why do we care so much about CKD? Because as was previously said, in 5 years, patients with stage 4 CKD are way more likely, 50%, to die from cardiovascular causes than to go into dialysis, 18%. So this is not a nephrologist problem. This is everyone's problem. And CKD and type 2 diabetes are strongly intertwined, so much so that for 600 million people living with diabetes, projected to be around 1 billion by 2045, and with 90% having type 2 diabetes, 2 in 5 have CKD. And we are not getting that much better in preventing kidney failure in patients with diabetes. Those are data from US adults with diabetes, and you can see that of all the complications of diabetes, we are getting better and better in lowering acute MI, stroke, amputation, and death for hyperglycemic crisis, but not so much in kidney failure. Last part of chronic kidney metabolic syndrome is arterial hypertension, and we know very well that arterial hypertension prevalence is increasing, has almost doubled in the last 20 years. And we know very well from meta-analysis of previously performed randomized control trial how important it is that we lower systolic blood pressure. So let's start with the FINE-ART program. So you know that very well, all the program of trials done on finerenone. How many of those patients have CKM? 90%. At least 2 or 3 components. only 10% had only one component of CKM, with the most represented being diabetes and chronic kidney disease. And it is not only about being highly prevalent. This is a study from the NANES survey in the US, so 11,607 US adults. And while 26% of them had at least one CKM component, you can see that the more component of chronic kidney metabolic syndrome they had, the more it was likely that the severity of the individual component was higher. Having both, you can see on the left, having both cardiovascular, kidney, and metabolic condition means not only having atherosclerotic cardiovascular disease or heart failure, mean very often to have both of them. And the same was true for CKD. When we take a look at observational studies, we can see that regarding the prevalence of CKM, the majority of CKM patients are patients with type 2 or type 1 CKM. I remember you that type 0 CKM is that not having any pathology, not even risk factor, so it is very, very healthy people, while stage 3 and 4 are patients with already established cardiovascular disease. So, of course, they are fewer than patients at risk of having a cardiovascular disease. Now, you will hear a lot from the next presentation of novel treatment for cardiokidney metabolic disease. So I like to shift a little bit the focus of the last part of this presentation on what we already have that we are using to treat our patient for other illness that may have an effect on cardiokidney metabolic pathway. So let's start with obesity. We know very well that the principal component of obesity is data intake. So for sure, being on a diet and having an active lifestyle are the main component to lower weights. We had some treatments earlier, like the sibutramine. However, the SCOUT trial almost killed the drug due to a higher risk of non-fatal MI and non-fatal stroke, despite a very good reduction in weight. And orlistat actually no cardiovascular outcome trial. You will hear out from GLP-1 receptor agonists, SGLT2 inhibitors, but metformin is a treatment that we often give to patients for metabolic syndrome, and in meta-analysis is associated with a 1 kilogram weight loss after 1 year. So it's not great, it's 1 kilogram, but it's better than nothing, and it's a treatment that we often already use for different indication. What about hypertriglyceridemia? We know very well from the VITAL study, patient in primary prevention, that receiving N3-PUFA was associated with a lower risk of cardiovascular events. However, does hypertriglyceridemia, or better, N3-PUFA, have an effect on chronic kidney disease? This is a meta-analysis published on BMJ. Those are 19 observational studies, so we're talking about association here, not causation. However, those are 19 observational studies showing a small but significant relative risk reduction of 0.92 for incident CKD among patients receiving N3-PUFA. N3-PUFA always have this very small but significant effect also in trial, for example, in heart failure, if you think about the GCHF. So we kind of expected that. What about arterial hypertension? We know very well of the treatment we do for arterial hypertension, but SGLT2 inhibitors, they have an effect on arterial hypertension. They consistently lowered arterial hypertension. Those are results from the CREDENCE trial. But what about GLP-1 receptor agonist? We actually performed a meta-analysis on this, and we showed that receiving a GLP-1 receptor agonist was associated with a 3 millimeters of mercury reduction in systolic blood pressure and 1 in diastolic blood pressure. We found a very high heterogeneity, and we explained this with weight loss. So it is unlikely that there is a real effect of GLP-1 receptor agonists on blood pressure, but is almost completely mediated by weight loss. But still, we are talking about 3 to 5 millimeters of mercury reduction in systolic blood pressure, something that is usually achieved in the trials focusing on blood pressure reduction. What about renal denervation? Another treatment that we usually do for patients with very resistant arterial hypertension. And renal denervation, while useful to actually lower blood pressure, is a treatment that usually raises eyebrows regarding kidney safety. So I would like to present you that when meta-analysis of trial on renal denervation were performed, we found no significant association between undergoing renal denervation and worsening renal function. Regarding metabolic syndrome and diabetes, we know very well that metformin is very good, as well as physical activity and lifestyle, to prevent new onset diabetes. But again, metformin, should we use them when eGFR goes below 30? We have no doubt on that. This is a target trial emulation study done in a Scottish court they took patients with diabetes, so we're talking about patients with established diabetes here, and the exposure was withdrawing or not metformin after a first event of eGFR under 30. The result was that actually withdrawing metformin was associated with a 26% higher risk of 3-year mortality. Again, observational studies, well analyzed, but still an observational study. What about new onset diabetes with ARNI and RASI? We know very well from randomized controlled trial that treatment with ARNI as well as treatment with RASi is associated with a lower incidence of new onset diabetes. Beta blocker seems to be associated with a higher incidence of new onset diabetes, however, with a very high heterogeneity, with atenolol seeming to be the one mostly associated with new onset diabetes, while other beta blockers seem to have a neutral effect. And lastly, the use of ARNI on liver function tests. You can see that in the PARADIGM-HF trial, patients randomized to sacubitril valsartan versus enalapril had a lower AST, ALT, total bilirubin, and alkaline phosphatase by the end of the trial. You'll hear a lot next about this, and I'm closing up. Thank you.
Thank you, Christian. Thank you for this very complete and nice overview. First of all, before introducing the next speaker, I wish you a good afternoon. And I would like to thank Gianluigi for arranging again this important appointment in Stockholm, which is the city that has adopted both of us. So I think now it's a pleasure for me to invite Dr. Beacom Botzgood from the US. She will talk about mineralocorticoid receptor and all the new target for treating cardiorenal metabolic disease. Please.
Thank you. I think that introduction was so fitting. Gianluigi gathers an incredible crowd over here. It truly is a pleasure to come and present. The topic I have is a very hot topic. The ALDO antagonism is gaining more importance, both for the heart failure as well as the whole cardio-kidney metabolic. In the next 10 minutes, the concepts I would like to emphasize are: the pathophysiology is now shared across all organs. We first recognize the maladaptive effect on hyper-excessive aldosterone expression in terms of the cardiovascular adverse outcomes, and the pathophysiology implicated both saltwater retention as well as maladaptive fibrosis, inflammation, all of which actually play a role in all organs. In the heart failure venue, we knew that these were critical, both for systolic as well as preserved EF heart failure patients. But now recognizing that these are shared mechanisms in kidney and heart, but also other organs. Keep in mind, the adverse outcomes are not solely for the heart in terms of the pump, but also arrhythmia, as well as maladaptive remodeling of the heart. In terms of the vasculature, there is evidence of course, hypertension, but also stroke. And for the kidney, we know the progression of kidney disease can be attributed to excessive ALDO, as well as elevated UACR. So in the context of this continuum, this actually probably is one of the mechanisms by which at the cellular level, we will see an importance of differentiation of agents and how they act. And currently, the framework of receptor antagonism is with non-steroidal versus steroidal, the good old spironolactone, eplerenone, versus a non-steroidal, which currently has the robust data from finerenone. The non-steroidal MRAs have more specificity for the receptor, shorter half-life, lesser metabolites, and a balanced distribution in the heart as well as the kidney. And we do have comparative data. So I'm going to first start with what do we know in terms of the CKD. With the steroidal MRA, unfortunately, we don't have that much data demonstrating prevention of progression of kidney disease. These are the two studies that has been carried out with steroidal MRA in CKD. both of which actually resulted in no benefit, and if anything, a signal for harm nominally in the first one, with an increased hazard ratio with spironolactone in individuals with CKD 3B and above. And that's the framework of what we had in the past regarding MRAs in CKD. The concept, though, is people may look at this saying, we just don't have data, or there hadn't been any studies carried out long enough. Majority of the patients in these studies stopped the steroidal MRA at 6 months due to the hyperkalemia and intolerance. The data that we have with the non-steroidal MRA is quite robust, especially starting from the kidney perspective, diabetic CKD or DKD, demonstrating both prevention of progression of kidney disease as well as cardiovascular outcomes in patients with diabetes and CKD. This actually has been shown in a pooled analysis of the two trials, Fidelio and Figaro, in the Fidelity pooled analysis, demonstrating a significant reduction in worsening of kidney function that eventually resulted in incorporation of non-steroidal MRA in the guidelines for diabetic CKD in a variety of guidelines. And we have now, since these guidelines incorporation, have now evidence from a newer study, confidence trial, looking at co-initiation of non-steroidal MRA and SGLT2 inhibition, demonstrating synergistic additive effect in reduction in UACR, thus more benefit for the patients that are high risk for CKD. For prevention of heart failure, we don't have any data or large-scale data that steroidal MRA, i.e. spironolactone and eplerenone, prevents development of heart failure. We have post-MI data when they have heart failure that they prevent progression of heart failure when their heart failure is present. But for stage A, individuals with risk factors, or stage B, asymptomatic LV functional or structural abnormality, we don't have data with spironolactone or eplerenone that it prevents progression of heart failure. Whereas with non-steroidal MRA, we do have data both from the Figaro Fidelio combined pooled analysis and Fidelity, which showed a very strong signal for prevention of heart failure, both by prevention of heart failure hospitalization, the first heart failure hospitalization events, as well as incident development of heart failure. And therefore, in diabetes with risk factors such as CKD, heart failure prevention has been incorporated in the guidelines as an indication for non-steroidal MRA. Individuals with type 2 diabetes and CKD, non-steroidal MRA is now recommended to prevent heart failure. And in terms of treatment of heart failure, yes, we do have the data with steroidal MRA, very robust, not only reduction in heart failure hospitalization and cardiovascular death, but all-cause death. And this is a differentiator, the magnitude of benefit and the concordance of benefit across all endpoints, starting with cardiovascular death and heart failure hospitalization, to all-cause mortality and heart failure hospitalization with steroidal MRA is quite robust. Do we have data with non-steroidal MRA? Not yet. We currently don't have trial data demonstrating efficacy in this domain with non-steroidal MRA, but they're being conducted. Steroidal MRA is one of the foundational therapies, one of the 4 classes that are indicated in heart failure with reduced EF. In PEF, we don't have that strong data with steroidal MRA. We do have a trial, TopCat trial, that unfortunately did not achieve significance in the primary endpoint. In the overall population, there was heterogeneity. In the Americas population, there was benefit. Those were the individuals who were certain to have heart failure. Some of the populations that were recruited from some other geographies, unfortunately, didn't have evidence of heart failure with preserved EF and unfortunately failed to demonstrate any efficacy. In the aftermath of TopCat, okay, where we didn't see significance with steroidal MRA in HFpEF, US guidelines put all of the agents, as you see over there, including ARNI, MRA, and ARB, as 2B recommendations because majority of the benefit was in lower EF, and as the EF increased, there appeared to be a ceiling effect or a lesser magnitude of efficacy. And these were post-hoc analyses, and for that reason, we put it as an 2B recommendation. But since that time, we now have evidence from a large-scale randomized clinical trial, fine arts trial demonstrating significant cardiovascular death and heart failure hospitalization, majority of the benefit attributed to the reduction in heart failure hospitalizations, even in the subgroup of individuals who were already on SGLT2 inhibition, and demonstrating also metabolic signal of prevention of new onset diabetes in individuals not even treated with SGLT2 inhibition or treated with SGLT2 inhibition. In the aftermath of the fine arts trial, the whole community is trying to decide whether steroidal and non-steroidal MRA is a class effect or they're different. And if so, how will they be incorporated in the guidelines? Canadian guidelines combine them, but the US guidelines, which is being launched in terms of the writing committee as well as the ESC, next iteration is to be determined. Most likely will be informed with the concepts in the following sense. The fine arts as well as the TOPCAT, the trial I told you that was non-significant, when looked at the Americas group have a signal. And when people do a meta-analysis of these populations shown in orange, show efficacy. But we also have other trials that are ongoing as highlighted with the yellow. SPIRIT trials, which will be with steroidal MRA in HFpEF, will be informing us whether the steroidal MRAs work in HFpEF. And then there is a large portfolio of trials being conducted with non-steroidal MRA in hospitalized heart failure with preserved as well as reduced EF patients, as well as individuals who are intolerant to steroidal MRA in the setting of HFrEF finality study. These will inform us. SPIRIT trials are going to come next, and I think overall will inform us. This is where the data is. Currently, we know that MRA works in HFrEF, where we don't have the data with non-steroidal MRA, and non-steroidal MRA works in HFpEF. And then in diabetic CKD, non-steroidal MRA has the largest evidence of benefit. And we have a variety of newer studies being conducted, either with non-steroidal MRAs as well as aldosynthetase inhibitors that are in the both HFpEF as well as heart failure prevention. And it's an era of combined therapies. As we heard from Christian, GLP-1RA is coming into the CKM world, as well as a variety of other medications. And I think we're going to be looking at combined therapies. We did see from the confidence trial of the benefit or the synergistic effect of combining SGLT2 inhibition with non-steroidal. This is an interesting study looking at the estimation of a lifetime benefit from combined therapies in individuals with type 2 diabetes and albuminuria. When you add therapies, as you can see, the benefit or the permutations of the additive effects of therapies. So in summary, steroidal MRAs are effective in HFrEF. Role in HFpEF less clear, pending 2 trials, which will inform us. Steroidal MRA have limited evidence of benefit in CKD, maybe potential harm. No evidence of metabolic benefit in terms of new onset diabetes or hemoglobin A1C profile. If anything, some studies implying adverse outcomes with steroidal MRA. Non-steroidal MRA improves outcomes in patients with HFpEF. Ongoing trial with non-steroidal MRA in HFrEF that is intolerant to steroidal MRA. And yes, it improves outcomes in diabetic CKD. And there are a large portfolio of studies being conducted with non-steroidal MRA, as well as MR modulators and ASIs in the management of cardio-kidney metabolic, ranging from prevention and treatment of heart failure to cardiovascular disease MACE endpoints and CKD. Thank you.
Thank you, Beacon. We're going to take questions at the end. And while you hook up Javed online, notice how we're moving in heart failure from neurohormonal approaches catecholamines and renin-angiotensin to metabolic fibrosis and inflammation. And the three drugs in this session are really a new paradigm. They're targeting not neurohormonal syndrome, but metabolic fibrosis and inflammation syndrome. So Javed on SGLT2 inhibitors, and shortly thereafter, Mark on GLP-1s.
Hi, Lars. Can you hear me?
Yes, very well.
Perfect. Well, again, I appreciate the opportunity to present, and my apologies that I'm not there in person. My disclosures are at the bottom. Of all the three talks, I think I have the easiest target, not because the physiology is any more beneficial with SGLT2 inhibitor, but because the data gaps are more mature and have been filled with more trials, whereas with other therapies, there are more trials going on, and we will learn a whole lot more on an ongoing basis. So just a reminder that it was only a decade ago that the treatment of diabetes used to be only management of hemoglobin A1C and other cardiovascular risk factors like smoking and lipids, but not specifically targeted in terms of long-term outcomes for diabetes per se, till, as we all know, that EMPA-REG outcomes trial came out. It showed for the first time that you can actually improve cardiovascular mortality in patients with type 2 diabetes. You can improve macrovascular outcomes, including MACE outcomes, and that it has started shifting the dialogue of not only hemoglobin A1C or glucose control, but actually improving patients' outcomes. But what is more relevant to our talk today are the two relatively, in retrospect, not surprising, but at the time, interesting findings. One is on the right bottom, the section D, which is heart failure hospitalization. This was an exploratory endpoint. This was not even hypothesized or in the part of the MACE, but there was a very substantial improvement in heart failure outcomes. And then the second was very substantial improvement in kidney outcomes in these patients as well. So that's where the dialogue got started, whether these drugs are cardiorenal risk-modifying drugs. If they are, based on what we know from pharmacodynamic studies and their impact on cardiorenal physiology, does it even have to do anything with diabetes that maybe both patients with and without diabetes will also benefit? But remember, at that time, there were also concerns whether this is simply a chance finding. So in the interest of time, I won't be able to go over comprehensively all the data, but at least the heart failure and the kidney benefit was shown over and over again with all sorts of SGLT2 inhibitors in various different populations. The cardiovascular mortality, EMPA-REG kind of stands out, and we can discuss what exactly does that mean. But the heart failure and the composite kidney, there are only numerical differences, maybe related to baseline patient population, but pretty consistent 25 to 35% relative risk reduction across all these trials. In the meantime, as Dr. Bhaskar has also mentioned, our thought process has also evolved about these cardiometabolic renal interactions, that these are not just linear reactions that, oh, if you have heart failure, you have poor cardiac output or congestion, so you develop kidney dysfunction. Or if you have kidney dysfunction, you have sodium and fluid retention, hypertension, and you have cardiac dysfunction. That actually both, and so diabetes and perhaps liver disease and all of these things develop because although these direct linear relationships are true, the other issue is this underlying sort of the milieu in which the body is living with inflammation and oxidative stress and endothelial dysfunction and adiposity and insulin resistance that simultaneously puts people at risk for all of these things. If this paradigm is true, then there are some bad news and a good news. The bad news is that this is the same paradigm that leads to development of disease and progression of disease. The more of these diseases you have, the worse the prognosis. And if you have one disease, the likelihood is that subclinically other disease has already started and will continue to progress over time. The good news, however, is that if this paradigm is true, then you might give the treatment of, with one of these agents for disease X or disease Y, but you will get benefit for multiple organ system, and you will have the same therapies reflecting prevention of disease, and if you have the disease, progression of the disease, and this is exactly what we are seeing. So based on all this, there were large heart failure with reduced ejection fraction trials were done, but they were not diabetes focused, regardless whether you have diabetes or not. Both trials, baseline medical therapy was very good, led to substantial reduction in cardiovascular death or heart failure hospitalization. And the hypothesis was true that with or without diabetes made no difference, you had the same benefit. This is not to say that these are only cardiorenal metabolic agents, that these are not diabetes agents. Of course, they are great diabetes agents as well. But in addition to the cardiorenal risk modification is irrespective of diabetes. This was followed by 2 heart failure with preserved ejection fraction. Remember, now we have data with finerenone and more data coming out with GLP-1, but at that time, there was not a single therapy that had conclusively proven to be of benefit in HFpEF till these trials came out. Again, consistent benefit, and now we have therapy that works across the spectrum of ejection fraction, and indeed, even within the PEF, whether you had mildly reduced 40 to 50, 50 to 60, or greater than 60, no heterogeneity, the benefit was seen across the spectrum. Again, in the interest of time, I won't be able to look at all the kidney trials. There are data with multiple agents. I'll just pick one example, EMPA kidney, with or without diabetes, the broadest population of CKD patients that were studied in this with low degrees of albuminuria as well, had dual endpoint, and both the endpoints, the dual endpoints were positive, kidney disease progression or cardiovascular outcomes as well. And keeping this theme of prevention, also reduction in the heart failure risk as well with SGLT2 inhibitor. Again, we have seen similar data with dapagliflozin and other SGLT2 inhibitors as well. Again, we have seen that in heart failure over and over again, that if a therapy works, it works irrespective of the baseline medical therapy. And in these secondary analyses, whether somebody is on a GLP-1 receptor agonist or not did not matter. You were seeing the benefit. So with these overlapping pathophysiologies and overlapping epidemiologies of type 2 diabetes, CKD, cardiovascular disease, we know that now the American Heart Association has come up with this presidential advisory about the CKM syndrome with various different stages of CKM. But the good thing is that these therapies can affect across the spectrum. This is a really cumbersome slide that we put together. I won't go into the detail, but we did a very detailed meta-analysis of what is the outcome benefit if you have only one disease or 2 or 3 or various different combinations of 2 or all 3. I mean, the bottom line is no matter how you slice and dice the data, you get benefit for multi-organ system. Dr. Boscott already showed you the data that combination therapy improves the outcome further. Right now, the big issue is not that we lack any data, it's the implementation gap that these therapies are picked up very, very slowly, especially in our highest risk patients because of the worry of side effect. These sicker patients have the least therapy given because the sicker patients who have the worst outcomes have the phenotype of potassium and creatinine and all of those things that we concern about blood pressure, that these therapies are not given. But in that sense, the SGLT2 inhibitor stands out because not only is there evidence gap, but tolerability gap for some of the other agents. SGLT2 inhibitor have sort of the most wide data in terms of low GFR going all the way down to 20, but in terms of tolerability as well, that these cardiorenal metabolic patients, dizziness, blood pressure, sodium, potassium, atrial fibrillation, creatinine, none of those things matter. They are very well tolerated. And indeed, we have many, many guidelines in primary care, in cardiology, in prevention, in heart failure, in diabetes, and in CKD that uniformly recommend these therapies. Thank you very much.
Okay, moving on. It is a pleasure to introduce Professor Mark Peter, on the use of GLP-1 receptor agonists in CKM.
So thank you very much. It's a pleasure to be here. I have to say Stockholm is a fantastic place. I came here 2 years ago for this meeting and dragged my wife and friends along and had a brilliant weekend with the Vasa Museum and great restaurants recommended by Camilla. So just really fantastic. So I'm afraid it's a short visit this time, but what a fantastic city. So I'll be controversial, I think, in the commentary rather than right now. In fact, I'll be controversial right now. Why not? So who in their day-to-day clinics with their colleagues, their cardiologists, their kidney colleagues, talk about this patient has CKM in the cath lab or the EP lab? Put your hands up if you say CKM in day-to-day clinical practice. Okay, one. Okay, who does it? Who talks about myocardial infarction, stroke, heart failure, kidney disease? Can anybody put their hand up at all? Yeah, they can. Excellent. Okay. So I think we should discuss that because for me and my colleagues, I've never heard of CKM. So we need to be careful about keeping the clinical community alongside the academic community. That's a really important point. Okay, I've got 10 minutes to talk about GLP-1 RAs across all of these different disease areas, which is impossible. So I'm going to talk in Scottish far too quickly so nobody can understand a word I'm saying. So I thought pressing the forward button would make it go forward. There you go. Excellent. Okay, here you go. So basically, all of you who are sitting here today, some of my colleagues think that weight management drugs are for somebody else. They're futuristic. They're something different. There are now 200 of these drugs in development. So this is going to become day-to-day life for all of us, particularly the younger people in the audience. These are cardiology drugs and they're going nowhere. They're rapidly expanding with tons of trials. So this is really exciting. And it's not just GLP-1 receptor agonists, as the title of the talk said. There's lots of other different mechanisms here, some of which I'll touch upon, but some of which I won't. But there are certainly some other agents that are fascinating because of potential benefits even above GLP-1 RAs. So Javad's given you the data about SGLT2 inhibitors and diabetes. So remember, these trials, these diabetes cardiovascular outcome trials were done to make sure we weren't killing people. So the diabetes drugs looked like bad things, giving people heart failure. These are safety trials. But just remember, looking at all these trials together, they're certainly good for cardiovascular endpoints. So when you're in a diabetes clinic, you would be thinking about using a drug with cardiovascular benefits. Again, Javad said people used to think of these as diabetes drugs. You see these benefits in people with high and low HbA1cs, but also with and without obesity. And remember that. So these are called weight management drugs or obesity drugs. In these trials, we saw benefit in people with and without obesity. So let's not think of these as weight management drugs or obesity drugs. Some of these trials are really important for heart failure fanatics like us. Some of the trials with the biggest benefits in terms of heart failure hospitalization reduction were with drugs that hardly did anything in terms of HbA1c reduction or weight reduction. So there's one here called Harmony Outcomes, which had a 29% relative risk reduction in heart failure that hardly affected HbA1c or weight. It was actually binned by the company because it didn't work, in inverted commas. So please don't think of these as diabetes drugs or weight management drugs. So I'm now going to talk about contemporary data, no old data, just contemporary data from now on in this updates meeting. So the first thing I was going to mention was SOUL. So SOUL was with oral semaglutide. Most of these drugs are injectables, and this is the first big outcome trials looking at oral semaglutide. So almost 10,000 people with diabetes and cardiovascular disease or chronic kidney disease with a conventional MACE endpoint. And of course, with oral semaglutide, we did see a reduction, not huge reduction, but 14% reduction in the conventional MACE endpoint. And there was a signal of possible heart failure benefit in SOUL. So this week, actually, we're going to see the formal publication of the SURPASS CVOT. So this is a fascinating trial. So the detail of this will be known about this week. We don't have the detail yet. We've all seen presentations. But the headline is that our tirzepatide was non-inferior to the active comparator to dulaglutide. So tirzepatide is a GLP-1 receptor agonist married to a GIP agonist against a GLP-1 receptor agonist by itself. So this is really interesting because normally we're getting GLP-1s against placebo. This is now active comparator. So more of these trials will be coming our way in lots of different disease areas. So fascinating. The difference between the two arms wasn't massive in terms of MACE, so 8%, but there was a 16% lower all-cause mortality. But this week, you can spend your Christmas holidays reading the New England Journal paper and look at the fine detail. So rapidly moving on to the kidneys, which we talked about are fascinating and important organs, apparently. So GLP-1s in kidney disease. So the poster child here is the FLOW trial. For some reason, they chose a primary endpoint of kidney things. I'm not quite sure why that is. But anyway, it was semaglutide 1.0 milligrams against placebo, a large trial for the kidney doctors, 3,500 people, diabetes and CKD. And again, looking at the important endpoints, no offense, MACE was reduced by 18%, and you see these other benefits, particularly the mortality signals being impressive. If you dig around enough, you can see some heart failure outcomes, and these go in the right direction, although they're not large numbers of events and not huge treatment effects. So I've already rapidly covered diabetes and obesity, diabetes and CKD. So what about obesity? So obesity is really where a lot of the action is going on. All of these hundreds of drugs going through all of these fascinating trials. We can discuss these issues in the discussion, but how much weight loss is right? What do you lose when you lose weight? How quickly do you titrate the drugs? What do you do maintenance-wise? There's lots of different things about your diet and exercise while you're on these drugs, oral, subcutaneous. So millions of things to talk about here. I just thought I would choose this trial was published 2 days ago, so I thought I would show this. This is retatrutide. So retatrutide is now a triple agonist, so GLP-1 receptor agonist, GIP agonist, and glucagon agonist. So you see these drugs getting slightly more complex. And this is a population with osteoarthritis and obesity, and this remarkable 29% reduction in body weight. So this area is fascinating. Literally every week, there's a new publication that comes out. So what about obesity and cardiovascular disease trials? So apologies for showing this. This is 2 years old. SELECT is the kind of massive trial, 17,500 people, obesity and cardiovascular disease, excluding diabetes. This is the 2.4 milligram weight loss dose of semaglutide, the GLP-1 receptor agonist, and time to MACE was the primary endpoint. So you all know this 20% reduction in the primary endpoint of MACE and a 21% reduction in heart failure event, where heart failure people. So looking at the data here, this is not great data. The HFpEF here was investigator reported. So no baseline echoes, no baseline BNPs. Somebody just ticks a box saying HFpEF. So you see there's lots of patients, over 2,000, but not a lot of events. Event rates are very low. So it doesn't really tell us very much, but the hazard ratio is in the right direction. So that's encouraging, but certainly not conclusive from a heart failure treatment perspective. What about HFrEF patients in SELECT? Again, this is a tick box, no echo, no BNP, just a tick box. Hardly any events here, 71 events only, but a signal towards possible benefit with a hazard ratio of 0.79. So the next 4 slides are just to give you a flavor of what's coming your way. Lots more cardiovascular outcome trials. So here's another one, SURMOUNT-MMO, tirzepatide against placebo, 15,000 patients. This is my Scottishness coming in. I get faster and faster. So REDEFINE, CagriSema, which is the Novo Nordisk, amylin, GLP-1 combination, 7,000 people, going down to BMIs of 25. TRIUMPH Outcomes, this is the retatrutide, the triple agonist, 10,000 people with MACE as a primary endpoint. SYNCHRONIZE CVOT, this is the Boehringer Ingelheim, survodutide, 5,500 people. So all of these trials are going to be published over the next 2 or 3 years. So again, fascinating area, rapidly moving, and you almost need an update meeting every week to keep track. So now I've done diabetes, CKD, obesity, now heart failure in 2 minutes. So what do we know? We've got some 2 small trials, one STEP HFpEF and the other called SUMMIT. And these are STEP-HFpEF is semaglutide, Summit is tirzepatide, looking at HFpEF. Both small trials, STEP-HFpEF was 1,400 patients, Summit 700 patients. And basically, they didn't show very much, but they showed reduction in weight and improved health status. They did show some other interesting things, like directionally favorable clinical events. Only 38 heart failure hospitalizations in each trial. So combine both trials, only 76 heart failure hospitalization. There was a reduction in NT-proBNP, which was good, and a reduction in CRP. But look at these treatment effects. So the hazard ratio 0.27. So if you believe that, a 73% reduction in heart failure, or a 56% reduction. But of course, we know in small trials, you see big treatment effects indeed validated in big trials. I just contrast that with the data which Bikram and Javed have shown you already. Tiny numbers of events in these trials against very large numbers of events in the previous trials. Death in these two trials, the two small trials, 20 deaths in total across the two trials. So these are inconclusive data. And in fact, in Summit, they went the wrong direction. But again, tiny numbers, you're a fool to overinterpret small numbers. So now there's a race on to see what the best drug is for heart failure: oral, subcutaneous, weekly, monthly, GLP-1 by itself, or add on, whatever you want to add on. Luckily, not luckily, but we're absolutely thrilled to be doing this large definitive outcome trial with Amgen's maridebart cafraglutide. And again, you need a lesson in pronunciation when you look at these trials. This is a large trial, 5,000 people with a proper endpoint, cardiovascular death or heart failure event. We're looking for 850 primary events in this trial, simple HFpEF population. So these are the kind of trials we need across heart failure area to show whether or not these drugs are beneficial. There's one other trial about to be announced, but we can't talk about that quite yet. What about obesity drugs and HFrEF? So if every day I get telephone from people around the UK and around the world saying, can I use weight loss drugs and HFrEF? And people want to do it before AF ablation, transplant, whatever you want, or just to make them better. So what's the evidence for that? So there are two micro trials in this area. So live 240 patients and fight 300 patients. So tiny trials. Live was Danish and had 1 death and 1 heart failure hospitalization. So you can't interpret that too much, I don't think. Neither of these trials are obese HFrEF populations. They're just HFrEF populations. And they're also not the weight loss dose of the drugs. Fight was the American trial. Again, very sick people. Everybody was within 2 weeks of hospitalization for heart failure, median ejection fraction 25%, 12% mortality in 6 months. And you can see the numbers of events there are pretty small. Deaths 19 against 16, hospitalization 63 against 50. So this is an unanswered question, but these trials make you a little bit anxious about these drugs and HFrEF, but certainly don't tell us the answer. So in the interest of time, I'm not going to tell you all the trials that are needing done, but you can imagine there's mechanistic studies needing done, outcome trials needing done. Just about everything needs clarified in HFpEF and in HFrEF. Also the rhythm issue as well. We see a slight increase in heart rate with these drugs. So looking at heart rate would be sensible. So lots of other trials, hospitalized people, non-obese people, people around the world with heart failure are very different. So we need to look at different treatment effects across different places. And of course, different adiposity measures. BMI is pretty bad as a measure of visceral adiposity. So we need to use different measures. Thank you very much.
Rafael?
Yeah, thank you, Mark. So we're open for questions from the floor or from the... Do you have a question or I can, yeah, please.
So Mark, very nicely done. The weight loss independent effects were seen in SELECT and FLOW, but in HFpEF, it looked like all the feel-good parameters were related to the magnitude of weight loss, i.e., most of the intermediate endpoints or 6-minute walk distance, health status, was better the more the weight loss was. So do you think HFpEF, the difference in HFpEF and obesity as to what we attribute our symptoms to, were these trials really HFpEF trials, or what is HFpEF in obesity? And is there more to it?
I'll tell you the meaning of life as well, just to throw that in. No, I think these are all exactly the questions we should be asking ourselves. These two very, very small trials were basically only granted to us because we pestered the companies to do an outcomes trial. And they said, everybody said that GLP-1 receptor agonist, but your heart rate up, we were going to kill people. So that was the whole narrative behind it. So we have small trials with functional endpoints. We can't tell very much. The answers to your questions, I'm not sure. In defense, we do have some indicators with those trials that maybe we do see a beneficial effect on heart failure. The BNP going down is interesting. We didn't expect to see that because as you get lighter, your BNP goes up. It was also very early we saw that. And the CRP reduction as well was very early as well. But what we need is definitive trials in all the populations I put up to tell us what's happening. We don't know, Bikram, and I've got the same questions as you do, but certainly there's lots of it is weight loss. We shouldn't be embarrassed about saying that. A lot of it is weight loss, but there probably is something else to it as well. But nobody knows the answer to that.
Cheryl?
Mark, I'm going to put you on the hot spot one more time. When we look about regulatory approval, HFpEF has been out for some time. Summit followed thereafter. Both were submitted to FDA, both pulled back, I think. I know it's rumors, not my country. I don't know.
But they were rejected.
And I think one's being put back in, maybe after some more data or analysis. I'm not sure. Wondering what's going on in Europe. And then also wondering what the fine print is on SURPASS CVOT that we should be paying attention to.
Yeah, so the first thing is the regulatory situation. So they were submitted and they were not accepted. So that's public knowledge. I'm not breaking any confidences. That's what happened, which I agree with because we were thrilled with the direction of the clinical events. I mean, 38 events, 8 in one arm and 30 in the other arm in favor of the drug is very encouraging, but nobody in their right mind would say that was enough for clinical practice change or guideline change or any indication change. So I think that's appropriate. But Shelley, I'm not sure if you agree with that.
It's interesting because I am quite certain that the companies all went to the regulatory groups to find out what a good supported endpoint would be. I will say, the Canadian guidelines, Bikram alluded to them. They recently came out. I think I sent them to most of you in the room here. And we did a strong recommendation for MRAs as a class, moved it up from a lower recommendation to a higher. But we did recommend also GLP-1 RAs based on our meta-analysis. And that was even before Summit in terms of reduction in heart failure hospitalization. So, it's interesting that the regulator, there's always a mismatch between regulator approval and guidelines. They don't seem to ever meet in the sweet spot.
So Shelley, I think I'm going to put you back in the hot spot again. So I looking at the meta-analysis that all of these trials, which I tried to show, are not HFpEF trials. They're people who are investigator-reported HFpEF. Their event rates are very, very low. They don't look like heart failure people. The number of patients is not very large. The event rate's low. The event numbers are low. So I would have rejected it too, to be honest.
Shelley, carry on if you have...
No. Just I thought you were going
to. So I think the Canadian guidelines we're here to be controversial. So I think they were charitable to the drug class. To be honest, for me, we need really, really robustly designed trials conducted with a very clear population with HFpEF. And again, Bikram's pointing out that maybe some of these people in the trials have debatable heart failure. In Summit, they had a mean BNP of 180. I think most people, if I had said to my colleagues in the corridor, I have a heart failure patient here, their BNP's 120, they would they would think that was surprising. I realize in North America there's a big obesity HFpEF phenotype, and there's a big debate about that. But still, that's for me, a lot of the patients probably had borderline HFpEF and included by things like hemodynamic parameters, the validation of which is not very robust, to be honest. The exercise hemodynamic parameters.
I would say in Canada, our guideline process is a very, I guess, somewhat rigorous process in which the methodologists essentially tell you what the data is and they give you the wording for your recommendation. And there's not a lot of alteration that you can make from a clinician perspective.
So we've talked about 3 drug classes. With SGLT2, there's no brainer. With MRAs, there's a question that will be difficult to answer of steroidal versus non-steroidal versus ASIs, aldosterone synthase inhibitors coming. So that's a big open question. For GLPs, what is the open question? Why are we talking about this since they are indicated for obesity and are or will be approved and subsidized for obesity? Why are we digging into the heart failure aspect? Is it because we think it'll be more compelling to clinicians, even though the indication won't be expanded? Or is it because we're seeking an independent expansion label completely independent of BMI?
The first comment I have is we don't have the safety in HFrEF, do we? And the concept of you could give it to anybody and every walking individual, I think, has not been answered. And in that context, we in JACC Heart Failure last year published a rather small and, of course, observational of what's happening to the ICD shocks. Similar to the signal that was seen in, FIGHT and LIVE, and, this heart rate increase and AFib and non-sustained VT, all those I think will need to be answered in a large-scale definitive trial that it is safe. Now, efficacy part of it is the MACE endpoints has been a consistent story in GLP-1 RAs, even in the diabetes trials. We've seen the MI and stroke go down. So the thrombotic events are going down. What's happening to the heart failure? And SELECT started this, FLOW also supported it. Without the MACE endpoints, the heart failure doesn't make it. Meaning, is this truly a heart failure beneficial? And back to your question, Lars, why do we care? So I'm going to start like safety is important. And then efficacy comes as a yes, the indications matter because I don't think we'll be able to afford giving it to the whole world population and putting it in water. And the proximate indication is by which these agents get covered and or paid for. And if it's for stroke, they cover it. If it's for MI, they cover it. Heart failure may make it more.
I'm just. We've got to come back on that. So, Javed, do you want to go first, or do you want me to go first back in the why do heart failure trials and GLP-1s?
Yeah, so I'll make a few comments, and I'll be a little bit of a purist, and I think that we are appropriately excited about incretin-based therapy, but also prematurely excited about these therapies, and I think we're extrapolating a little bit too much. I am equally excited, and if I were to be a betting person, I would bet probably every single chip I have that these trials are positive. However, that does not mean that we should just go ahead and give a recommendation for clinical use without the evidence from clinical trials. And here are some of the reasons. So one, in heart failure, we obviously have a history of things that improve biological markers, but in trials ended up having higher risk of mortality, hospitalization. In heart failure, we have examples where therapies made people feel great. Their symptoms got better, quality of life got better, but also at the same time increased mortality, hospitalization rate. So heart failure, you may or may not be able to take the lessons from other diseases. I actually don't know. I know that at this point, we are completely overruling that weight loss associated with worse outcomes or lower weight associated with worse outcomes in heart failure is epidemiologic paradox, and I get it. Having said that, is the degree of weight loss of no consequence in heart failure? I don't know. I don't know what we have learned from obesity. losing 20%, 25%, I mean, at some point is it detrimental? I have no idea. The lean mass loss is associated with not only skeletal or your liver mass, but it is also associated with reduction in LV mass. Is reduction in LV mass in patients with eccentric hypertrophy good or bad? I actually don't know. If you look at the SUMMIT trial, their mortality hazard was 1.25, going in the wrong direction, which again, I am 100% convinced is nothing. It's a nothing burger. It's a small numbers, lots of missing data and all that kind of stuff. Having said that, we just don't know. And I think that unless and until we do mortality morbidity trials, this question will always be out there. And I think it's a little bit premature to jump the gun.
Yeah, I'm just going to add a bit, Lars. So it's a great question, though. So I don't know what the HFpEF trials, the results are going to be, whether they're going to be a tiny treatment effect or a massive treatment effect. And safety, as Bikram says, is vital. So I think we absolutely don't know the safety and efficacy of these drugs yet. That those two small trials, which are heart failure trials, have, pretty well populations, obesity, related HFpEF, but very small numbers of events, and they just open up the possibility that they might be helpful. But again, we look at across all of our history as cardiologists doing trials in different disease areas, they're very informative. You get differing treatment effects and different safety in different populations. So for me, the life and fight are. I'm not dismissing them there. I'm just saying they're big holes here. But then where does that stop? Ejection fraction 35, 40, 45, 50, 55. We need to do a lot of trials, and we are going to do the trials, and we'll come back, and these trials will probably finish 2028, 2029, some of the first ones. So we'll have data soon to discuss. And let's remember this conversation. We think they're going to be home runs. I'm not sure they are. We're doing them really to find out what the benefits are.
And I'm going to add, heart failure is going to be critical as an endpoint for primary prevention, i.e., prevention of development of incident heart failure is a critical one that is actually identifiable and I think is a signal for longevity, maladaptive pathophysiological processes at the cellular level. Meaning what we're trying to abrogate here is oxidative stress, inflammation, fibrosis, which is part of aging and dying and maladaptive and organ damage in all diseases. So this is actually a pathophysiological entity, and we are trying to figure out, I would be very excited if this has got nothing to do with weight loss. And when given at smaller doses, that doesn't result in, let's say, the magnitude of weight loss it does in maybe less sicker populations or earlier populations to be put on board, despite all our horrible diet and so forth, is being protective for young individuals for the long term, for prevention of diseases across the board. It's an interesting concept. And I think in that context, heart failure is going to be the surrogate signal, meaning, things going in the right direction when you prevent heart failure. And we're going to start with that for prevention.
If I may add one more comment, quickly one more comment, and that is, this also reminds me of this discussion. Look, I mean, I would be, clinically speaking, I'm completely on board. It's like, why do we keep doing these large trials and why can't we just extrapolate? The only problem is that we have a whole track record of sort of extrapolating and not being correct. Reminds me of the statin days that every single trial was positive, and when patients with CKD, it was trial the dialysis population, the same questions were being asked, that you're taking population which is enriched for cardiovascular events, why do you need the trial? And obviously it showed nothing. But a more cogent example would be that when NOACs and DOACs were coming out and all the trials were positive in stroke and atrial fibrillation, in valvular disease, in prosthetic valves, this question was again raised, like, why do we need a trial? It's an anticoagulant, and that trial was stopped early for harm. So, I mean, these diseases differ differently, and I think we really need the data.
I would like to remind the faculty that the session is treating cardiorenal metabolic and not to be focused too much on heart failure. I understand that this is kind of but along this line, I mean, what do you think, and it's open to all of you, about the combination therapy of SGLT2 and GLP-1, incretin-based therapies, when you consider the wide spectrum of the cardio-kidney metabolic disease?
I think that for sure, starting with SGLT2 inhibitor and GLP-1 receptor agonist will likely be the way to go, given that trials are positive for other pathologies. Like, for example, if you think about arterial hypertension, we for sure know that patients with obesity receiving GLP-1 receptor agonists have a lower blood pressure by the end of the trial. We have the same data on SGLT2 inhibitors. However, when we compare those treatments with other that are only reducing blood pressure, like calcium channel blockers, they also have an additional benefit on cardiovascular mortality and MI. So in the future, it is very likely that we may start with those. When we think of weight management and weight loss, there are also evidence pointing to SGLT2 inhibitors being associated with around 1.5 kilogram of weight loss by the end of the trial in the trials performed as of now. And the same is true for kidney outcomes for renal trials. So in the end, I find it very likely that they will become I will not say standard, but for sure, very, very used for prevention. Not sure regarding specific pathologies, like for heart failure, for sure we need trials. And we have evidence for MI, so for secondary prevention, at least we have some evidence from GLP-1 receptor agonists, not yet for SGLT2 inhibitors.
So I love meetings like this because my lens is so different to others. So I want to say a couple of things. First thing is around the non-steroidal MRAs, and we mentioned the Alchemist trial. And Achieve as another trial of non-steroidal MRAs. We need to remember that they were in people who didn't have a diagnosis of heart failure, actually. So they were looking at reduction of heart failure and cardiovascular events in people enriched for poor cardiovascular outcomes, but they didn't have a diagnosis of heart failure at enrollment. So we just need to be really thoughtful that doesn't mean to say that for people with heart failure syndrome, that we wouldn't necessarily treat them with non-steroidal with spironolactone just because the Alchemist or Achieve studies didn't show an outcome. I just want to be really clear on that, because actually I think for people on dialysis with heart failure, the data is not there that they wouldn't benefit actually. And the second thing I would say is that we're still talking about these as weight loss medications, but from FLOW, that was not a weight loss mediated outcome. And so for me, we've got to the point for people living with type 2 diabetes and CKD that we've almost got to the point on GDMT that we have. This was talked about at the ASN at one of the state-of-the-art lectures, that we're getting to the point where we can cure CKD because we're bringing back the progression of CKD over time in line with an age-related decline if they're on all of their pillars of therapy, including a GLP-1 receptor agonist. And that's independent of weight loss. So the questions that I'm being asked is, at what point of BMI would you think it would be unsafe to start this drug? Because it isn't about their BMI or about their weight loss. It's about the preservation of their kidney function, actually. And I think we're going to start to see more data around the weight loss independent factors, and then we will just be looking at this in a very different way. So I just caution, I accept that the language around heart failure is very important, but for people with CKD, the narrative is slightly more nuanced because it isn't about weight loss.
So if I may just quickly add one comment, that's a nuanced but a really important point that was made, because we spent about 5 years fighting that SGLT2 inhibitors are not diabetes drugs alone, right? So they are cardiorenal risk modifying drugs. But when you have the label of a diabetes drug, there's a lot of opportunities that are lost in the clinical practice. And I think just labeling them strongly only as obesity drugs have this connotation that people will, for a whole lot of reasons, may not want to treat or may not want to be treated for obesity, and you pigeonhole yourself in that. And thinking about these as cardiorenal risk-modifying agents, just like we did for SGLT2 inhibitor, may be really important.
So Jared, you showed a fabulous slide about. So I don't think the data about SGLT2 inhibitors is controversial at all, and you showed a fabulous slide about that problem with implementation of the guidelines, and that there is a huge implementation gap. And my worry would be, again, I'm in clinic and I'm thinking I'm going to prescribe that Ozempic for the management of progression of kidney disease, and someone will say to me, well, that's a weight loss drug. And we have to think very carefully about that, because it is a problem with unpicking that further down the line, in the same way that SGLT2 inhibitors are diabetes drugs, and we're still unpicking that. So that's a fantastic point.
And again, this is a very US-centric comment. I don't know whether it's applicable to Europe or other regions of the world, but we are also coming at the heels of almost a decade of a very well-intentioned social trend, so that we don't shame overweight people, where there was this whole body positivity movement and all these things about healthy at all weights and whatnot, that there was actually a little bit systematic downplay about the issues related to obesity, and not everybody wants to be treated. So if you only label it obesity, there are still all of these other social connotations that go with it, but those are not the same for medical therapy.
Thank you very much. This has been a very, very interesting session about a very exciting and expanding area. And so thank you to all the contributors. And I think we're going to need some iron after this one. So it's going to be a session on iron HF starting in 20 minutes. But first, some coffee. Thank you very much.